Thank you very much, Sanjay, for the introduction. And what I would like to do is to maybe spend a few minutes talking first about NAFLD or MASLD or MAFLD, with whatever terminology it's your favorite terminology in the region. But it is a common disease. So at this point, what I'm going to show really is can be applicable to any nomenclature that people use. As you all know, and I'm going to cover first the epidemiology, the stratification and treatment of MASLD. Then we'll talk a little bit about the other extrahepatic manifestations, really focus the last part of the talk on sarcopenia and its importance and assessment, and then how do you treat it. This is from the most recent meta-analysis that showed the global prevalence of MASLD. And that prevalence is about 30% or so. The highest prevalence in this study was reported from Middle East and North Africa, as well as Latin America. But when you look at the rest of the world, the prevalence is higher than 25%. So at least a quarter of the world population anywhere in the world will have MASLD. But if you happen to be in North America, about a third of patients, and Middle East and North Africa, 36%, and in Latin America, over 40% of individuals will have MASLD. Another important point is that when you look at sort of the studies that have been reported over time, and you focus only on the studies that are recent, then the prevalence of MASLD in the most recent sort of studies is about 38%. So if someone asks me what is the prevalence of MASLD today, I'll say it's about 38%. That's a very high prevalence rate, obviously. Now, MASH, it used to be called NASH, of course, is a subtype of steatotic liver disease. And this is a diagnosis by histology in general. So you can't really determine directly what's the prevalence of MASH or NASH in the general population. So you have to estimate. And that prevalence has been reported to be about 5% or so. Again, very high prevalence in the Middle East, North Africa, as well as Latin America. But again, in most regions of the world is about 5% or higher. Another, of course, important issue is the potential tsunami of MASLD that's going to come because our kids are getting obese. And this is an older study that suggested the prevalence of NAFLD at the time, or MASLD now, among children is about 7.6%. I would say that this is an underestimation. And you look at another study we published looking at NHANES, and looking at the adolescent population, prevalence was 15%. So I would say that the prevalence of NAFLD or MASLD in kids is probably about 15 to 20%, in fact. Now, how about type 2 diabetics? The two major driver of this disease is type 2 diabetes and visceral obesity or central obesity. The prevalence of MASLD among type 2 diabetics, we initially reported doing a meta-analysis published, I think, in 2018 or so, that prevalence was about 55%. This is the most recent meta-analysis published this year that suggests the prevalence is 65%. Again, the region of the world that has a lot of diabetes and MASLD have very high prevalence rates. Middle East stands out with a prevalence of about 71%. Again, when you look at the studies that are more recent, if someone asked me, what is the prevalence of MASLD in type 2 diabetics, I would say that it's about 69%. Very, very high prevalence rate in this population. Now, the progression of this disease is not linear. So those patients that have steatotic liver disease and happen to have just fat in the liver, most of them do not progress in terms of liver disease, but they still have a high rate of mortality from cardiovascular causes. Now, the group that has MASH or NASH. That's the group that will progress about 15 to 20% to cirrhosis and its complications. The progression to cirrhosis probably takes about a couple of decades, so it's a slow progression. There are two peculiarities about this. One is that the progression is not really linear. So there are periods of time where patients are progressing, and there are periods of time that patients are actually regressing or remaining stable. That makes it very difficult for clinical trials where there's a placebo arm, because patients in the placebo can actually improve spontaneously if you're looking at fibrosis as a surrogate of progression. So progression can happen, and net it happens maybe about 10 to 15% of the patients will progress. But an individual patient, there could be progression, regression, or stability that makes it complicated. The second peculiarity about this disease is that, like all other liver diseases, once you develop cirrhosis, there is a risk of hepatocellular carcinoma, which is about 2 to 3% per year. So that's within the threshold to be screened for HCC. On the other hand, MASLD, similar to hepatitis B, can develop HCC in the absence of cirrhosis. Now, that's problematic because the number of patients that have MASLD, as you saw, 38%, is huge. However, the progression rate is actually relatively small. So it's about somewhere between 0.1 to 1.3 per 1,000 patients per year. That's actually below the threshold of screening for HCC. So although you have to look at some risk factors, the current guidelines suggest that if you have a patient with MASLD without cirrhosis, to screen, you probably have to look at multiple risk factors. So if a patient has a family history of HCC, or if there is diabetes, because remember, there is actually an independent association between both diabetes and obesity with HCC. So if they are, especially if they are diabetic, or they have some genetic profile, then those are the patients that you can at least consider case finding. It's really no longer actually screening. So that's sort of the two peculiarity of this disease, that the disease progression is not linear, and that HCC can happen in the absence of cirrhosis. Now, what are some of the things that causes this progression? And I think the most important probably organ that plays a role in the development of progressive liver disease is white adipose tissue. And as you know, white adipose tissue is an endocrine organ that produces a lot of inflammatory and anti-inflammatory adipokines and cytokines. And this really leads to damage to the liver cell, causing sometimes lipid peroxidation of the membrane of the hepatocytes. That really ultimately leads to ballooning, and then and also to activation of stellate cells and fibrosis, and ultimately cirrhosis. There are other components that play a role here. Dysbiosis of the gut, and then anything that increases oxidative stress have been associated with more progressive liver disease in this context. Now, let's look at evidence that this is, what's the evidence that MASH can lead into significant mortality and morbidity and complications. So cirrhosis, this is from a meta-analysis that's being updated right now. So if you look at NHANES database, which is the United States database for the general population, prevalence of MASH-related cirrhosis is about 1 to 2%. If you look at the meta-analysis that we performed, this was presented this year at the DDW here, it's lower, it's about 0.31%. So we need to figure out exactly where the prevalence of MASH-related cirrhosis is. It's probably between 0.5% to about 1.5%. Now, if you look at patients that have MASLD and look at proportion of patients that meet the criteria for MASH cirrhosis, that's about 5%. That's about 5%. And mortality rate, as you know, is of course higher. It's probably about 7 per 100 patient per year. Now, because cirrhosis is very common in these patients, and of course, some of these patients undergo liver transplantation, you can see that now NASH is the second indication for liver transplantation in the United States. Now, if we change, this is for non-HCC patients, patients who are listed for decompensated liver disease. Now, if you change this to liver transplantation in the United States for HCC patients, then MASH is the #1 indication for liver transplantation. Furthermore, in older patients over the 55 and also women, MASH is now the #1 indication for liver transplantation in the United States. Hepatitis C, as you see in the green light, is coming down to very few patients getting transplanted for hepatitis C. So it's all with MASH and alcohol-associated liver disease at this point. This is, again, the mortality rates that came from our meta-analysis. And as you can see at the top, that the most common cause of death among patients with MASLD is cardiovascular, followed by extrahepatic cancers, followed by liver. Now, liver is the third most common cause of death. If you look at the population in general, it's the 12th cause of death, at least in the United States. So there is a concentration of liver-related mortality amongst these patients. In fact, these three causes of death basically is responsible for about 67% of all deaths among patients with MASLD. If you look at the bottom, I think things will flip here. So once you develop advanced fibrosis and cirrhosis, then liver is the most dominant cause of death. So for patients who have, F3 and F4, then liver becomes the most common cause of death, and cardiac is the second most common cause of death. Now, some of this data came from meta-analysis and some of the data from USPTN, which is the transplant network in the United States. This is the global data from GBD, the global burden of disease. And here we're looking at really two complications of MASH or of liver disease, liver cancer and cirrhosis. Now, 95% of liver cancer here is basically HCC. And we have looked at 4 different diseases, liver diseases, MASLD, alcoholic-associated liver disease, hepatitis C, and hepatitis B, both in terms of liver cancer and also in terms of cirrhosis. What you see, the numbers here is the annual percent change between 2010 and 2019. And so it tells you if the numbers are changing in a positive or negative direction. So the red suggests that there is an increase, and the green suggests there is a decrease. So if you look at most of the regions of the world, if you look on the left, these are the regions of the world according to GBD, you'll see that, say, under hepatitis B related, cirrhosis-related deaths, so there are a lot of greens suggesting that hepatitis B, the mortality from cirrhosis, is declining, suggesting that whatever we're doing in terms of vaccination or other things has actually led to a decrease in cirrhosis-related death related to hepatitis B. If you look at the liver cancer death and look at MASLD or NAFLD here, there is a lot of red. And even in the cirrhosis, there is a lot of red or pink red that you can see, suggesting that there is an increase in almost every region of the world related to this liver disease. Now, there are 2 sort of important predictors of adverse outcome in these patients. The first one would be sort of under the umbrella of the clinical drivers of mortality. And type 2 diabetes is probably the one that's the most predominant driver of both fibrosis, cirrhosis, and mortality in these patients. This is one of the oldest studies that we published in 2004, looking at the cohort of patients that had a long-term follow-up of about 30, 40 years or so. And NAFLD patients with diabetes, compared to those who had NAFLD alone, had higher rate of cirrhosis, higher rate of liver-related mortality, and also overall mortality. This was the first that suggested that having NAFLD in the context of type 2 diabetes is bad. Not only it's more common, you see much more MASLD and MASH in that context, but it's also a major driver of mortality. Now, not a paper published with biopsy, and you see that the more component of metabolic syndrome you have, the more the higher chance of advanced fibrosis. And when we looked at and this is a study we published from NHANES, which is general population data, again, the more component of metabolic risks you have, the higher the rate of the likelihood of mortality, the risk of mortality. So this is really what led to the change in the nomenclature to connect this to the underlying pathogenic pathway of this disease, which is metabolic abnormality and metabolic syndrome. And that's how we had MASLD as one of the reasons for development of that name. Now, there's, of course, on the change of the name, there was the issue of fatty liver, that it could be stigmatizing. We've done a major, large stigma survey of both providers and patients. It looks like about 8% of patients with NAFLD thinks that stigma is related to MASLD or NAFLD. Most of the stigma comes from obesity, not really from NAFLD. Regardless of that, the new nomenclature connects the metabolic abnormality to the disease. Now, another important predictor of mortality is where you start in terms of stage of fibrosis. And we did a study in 2012 in hepatology that started a lot of this discussion. This is the most recent meta-analysis of multiple studies over 4,400 patients. And you can see that once you hit stage 2 or higher, then both liver-related mortality and all-cause mortality will increase. And this is really part of the reason that clinical trials of NASH has put, or at least in the United States, the FDA and in Europe, EMA has required the use of stage of fibrosis as a surrogate of mortality. Now, there is some data to suggest that if you regress fibrosis, there may be improvement in clinical outcome. This came from two cirrhotic trials, STELLAR-4 and simtuzumab clinical trials. They were done by Gilead Sciences. None of these drugs worked. On the other hand, when you look at those who actually regressed in terms of their fibrosis, which happened to occur in about 16% of patients over about 48 weeks, that those patients that had regression had lower rates of liver-related events, suggesting that if you regress fibrosis, outcomes may improve. And of course, that's just at least an indirect evidence for that. Now, on the other hand, liver biopsy was something we used to do quite a bit when I was in my training, but now 30 years later, no one wants to do liver biopsy. So we have to find ways to use non-invasive, develop non-invasive tests to predict as a surrogate of fibrosis. Now, these are not tests for fibrosis. Remember that that's actually not the case. But when you look at the test that's been used for risk stratification, FIB4, which was initially actually developed for hepatitis C, this is now the first line testing, non-invasive testing that's been recommended by everyone, by all guidelines. 1.3 is the cutoff that we use, at least in the guideline that I'm involved with. I've been involved with a number of guidelines, but currently with the ADA guideline that's going to come out probably in the next 6 months, and also the global guideline that we're developing. The cutoff is about 1.3, and really what you do is to look at if there's less than 1.3, the likelihood of developing advanced fibrosis and adverse outcome is very low. So those are the patients that need to go back and be followed by their primary care. For anyone after higher than 1.3, then we would recommend a second test, and we'll review that in a second. Now, the other test that's been used quite frequently is to assess the stiffness of the liver with technologies that use ultrasound technology, and transient elastography is the one that we use more commonly in the United States. Shear wave elastography is there as well. and of course, MR elastography. And this is for the transelastography, a cutoff about 8 is what we use to sort of stratify patients. Less than 8, the risk is very small. Now, more recently, they have actually put together components of transelastography: CAP, which is the assessment of fat; liver stiffness, which is a surrogate of sort of staging outcome, probably not fibrosis; and AST, calling it FAST score, which basically gives you an idea about not only stage but also potentially the how active is the disease of MASH. So these are the cutoffs for the FAST score, and there is more sophisticated version of this called Agile 3 and Agile 4. And more recently, those tests have been shown to have pretty good predictive capacity for patient cohort that Dr. Vincent Wong led, this large cohort of patients from multiple different countries, and showing that both Agile 3 and Agile 4 could predict mortality. Now, a test that is more of a fibrosis test is ALF test, and it measures hyaluronic acid, P3NP, and TIMP1. These are fibrogenic and fibrolytic components. And the bottom line is that when an ALF test, an enhanced liver fibrosis test, is actually approved in the United States, it has good sensitivity and specificity for some patients, especially once you get to an ALF score of greater than 11.3. That's actually associated with pretty bad outcomes. So that's an important number. Now, what is the cutoff? To the lower cutoff initially was suggested it's 7.7. That is probably not accurate. That's probably too low. Others in the European guideline that came out last month, it's 9.8. But 9.8 probably is the number of patients. Hello? So the cutoff that we use is 9.2, and we'll hopefully show that that's probably an important cutoff. MRE, as I mentioned, is also a measure of elastography. It's more accurate than transelastography, but probably less available and more expensive. A cutoff of about 3.6 probably will suggest more significant fibrosis. Now, I showed you the numbers in terms of the cutoffs that you'd use for ruling out significant fibrosis adverse outcome. Now, these are the studies that I've actually looked at outcomes longitudinally for. This is a study of over 20,000 individuals and looking at NASH-related clinical events. This is from the UK Clinical Practice Data Link. And when you look at those patients that had either an increasing pattern of FIB4, which happened, that the increases happened about, happened in some of these patients, they have higher rate of events than those patients that did not. So the overall progression with baseline FIB4 is about 12.8. Those who showed an increase in their FIB4, the events went to 18.5, and then for those who had a decrease, then it dropped to 10.1. So that suggests that FIB4 has a good predictive model. Another one is transelastography that we looked at. This is the transelastography data from ENHANCE. It was published by Villar Gomez. And again, when you look at the patients who had a transelastography of less than 10 in the first graph versus those who had between 10 to 19.9, or those who had more than 20. More than 20, you can see that there's a decline in survival. And that less than 10, usually it wouldn't actually impact survival by much. Now, this study also looked at CAP and determined that CAP of 285 is probably more important, that those who had CAP or liver fat indicator of more than 285 dBm, that these are the patients who are at risk for adverse outcome. ALF test, we published this in gastroenterology a few years ago. This is again from the clinical trial data set. And when you look at if 3 patients or if 4 patients, having that cutoff of 11.3 was predictive of adverse outcome. And finally, MRE. When you look at the distinguishing sort of threshold for cirrhosis, that's about 4.39. And when you get to about 6.4 or so 6.5, then you're talking about decompensated cirrhosis. You get to about 7 or higher, then they get into hepatic encephalopathy, and then a MRE of 10 or higher is associated with very, very advanced liver disease. So MRE can also predict the outcomes. Now, a lot of us have put together sort of algorithm. I'm sure you have one for your societies. But when you look at the most recent guideline that was published, which is from EASL, it was a month ago. I like it very much because it's really very, very easy to understand. Is that if you happen to have a patient who's at risk, like those who have type 2 diabetes, or they're obese and have another component of cardiometabolic risk, like dyslipidemia, or someone who has persistently elevated liver enzyme, then FIB-4 is the first test to do, which is basically what you're recommending, is that less than 1.3, reassess every year or 3 years, depending on whether they have risk. So if someone has cardiometabolic risk, you probably would need to screen them every year. If they don't have any of those, then you could probably go back to every 3 years. Now, there is the intermediate score of 1.3 to 2.67, or the high score of 2.67. Now, in this guideline, they suggest that those who have the intermediate, they can go either through intensified management of comorbidities and follow FIB-4. I'm not a fan of this. I think FIB-4 for assessment of intervention is not good, or go directly to a VCTE, which is the second test, which is what I would do. And what are your in the intermediate or high score, then getting a VCTE that is now 8 or higher, then will require a referral to gastroenterologist and hepatologist for additional treatment. Now, what are the treatments? This is really a summary of lifestyle modification. You can talk a lot about this, and of course, diet is summarized here. In the United States, we recommend Mediterranean diet, but of course, whatever diet that's comparable to this type of diet in the rest of the world, which is high in vegetables and fruits and fish and white meat, whole grain snacks. These are sort of the preferred, as well as nuts and seeds. This is preferred sort of diet approach. Activity, I think it's important that you combine both aerobic activity with resistance. That would work the best. And if you combine diet with sort of nutrition with activity, you probably will get better impact. It's also important to remember that ultra-processed foods are probably one of the worst actors here, contributing to development of diabetes, obesity, and of course MASH. And that's on the last box that is sort of summarizing some of these. And of course, minimizing alcohol and smoking cessation also potentially improve outcomes. Now, I'm just going to show you two slides about drugs. These are the phase 3 clinical trials, so I'm just going to focus on those. Obeticholic acid, as you know, it was an FXR agonist and worked well in terms of clinical trial data, but the United States FDA Advisory Committee recommended not for its approval, so the program stopped. Aramcol is actually on hold right now. Resmetirom, as you know, was approved in the United States in 2024, and I'll show you some data on MAESTRO-NASH. And then you have a number of other drugs, semaglutide, lanifibranor, epiruxyfirmin, and then pegosyfirmin are the studies that are on the drugs that are ongoing. I'll show you just a couple of these. This is resmetirom. As you know, it's a phase 3 clinical trial published in New England Journal of Medicine earlier this year with my good friend, late Steve Harrison, being the lead author. Of course, we miss him. He's a wonderful investigator and contributed to our field greatly. When he published MAESTRO-NASH, he showed that when you look in the bottom, that there was actually significant improvement improvement in NASH resolution, as well as one-stage improvement of fibrosis. So that, of course, is important. When you look at the top, you'll see that, from my perspective, it's only important if patients are not only improving, but not changing and stabilizing. Because if you stabilize in NAFLD, you're not going to die of liver-related mortality. So when you look at those who worsen versus those who actually either improved or changed, you'll see that over 80% of patients actually either improved or did not change and stabilized. So that's actually a very good number for most of our patients. Now, not only histology improved, but also a number of the non-invasive tests improved. MRI-PDFF probably was the best predictor of histologic response. Now, this is what we recommend. This came from a recent publication of how to use resmetirom, and that's applicable to the United States because resmetirom is only approved in the United States. So if we see, and of course, when FDA approved resmetirom, it approved it without a liver biopsy. So you can use NITs to start treatment or to monitor. So you clearly treat patients that have F2 patients, and these are those who have a VCT of 10 to 15, but they don't have any evidence of portal hypertension or cirrhosis, because this is the portal hypertension, which is on the red box, or cirrhosis is a contraindication. So a VCT of 20 or higher, MRE of 5 or higher, alpha of 11.3 or higher, these are the patients you should not treat. The ones which is in the middle, that's probably more consistent to an F3, 15.1 to 19.9 VCTE. This is the group that I personally do a second NIT to confirm that they are within the range, that they're non-cirrhotic. If they're non-cirrhotic, then there's no reason not to treat these patients. In terms of treatment, you start resmetirom, and within 3 months, we do an assessment just to make sure that liver enzymes are okay and that patients are tolerating. But the actual assessment of efficacy is done at 1 year. Nevertheless, at 6 months, we will do again an ALT and a VCTE. I don't do PDFF, but that's what they were recommending also, just to get an idea that the patient is actually progressing. At 1 year, you will basically look at the patients if they have worsening NITs. If they're worsening NITs, and I actually consider at least 2 NITs to be worsening, then those are the patients that are clearly worsening, and I would stop their treatment. Others who actually clearly respond, and that's actually having a VCT of 30% or higher, and the stiffness or an MRI-PDFF of 20 or 30% drop, or an improvement of ALT by 17 unit, those are the patients that clearly, and I personally continue because I don't have anything else to do or to give them. Now, of course, there's a controversy in terms of those who do not change, not improve or worsen, clearly what to do. Now, if these patients are tolerating, and in the United States, of course, insurance and coverage is a major issue, then I personally will continue those patients as well. And how long to treat, it hasn't been determined. If your metabolic risks have not changed, I suspect that the minute you stop, then the disease will come back. And that would be much more important for a patient who has F3 than a patient that has F2. So the other drugs that we can look at, lanifibranor on the left top, there is improvement of both MASH phase 2 clinical trial. Semaglutide at the top showed improvement of steatohepatitis, but did not show improvement of fibrosis. Phase 3 should come out later this year and will tell us. Pegozaforman or efruxifermin, they actually have shown significant improvement of fibrosis and some improvement of steatohepatitis, but again, they're phase 2, they're ongoing phase 3 clinical trials. Now let's go into the extrahepatic diseases that are associated with this disease. So this is really a metabolically driven sort of collection of different diseases. Heart disease we have talked about, increased mortality from cardiovascular, malignancy, gastric malignancy, pancreas, lung is increased in these patients, as you know, and this is actually independent of obesity. In the studies that were done, multivariate analysis, NAFLD was independently associated with these malignancies. Chronic kidney diseases, of course, very important, sleep apnea, and others that are mentioned here. Let's now look at one really under sort of estimated and probably underemphasized complication of MASH, and that's sarcopenia. So just to do a little bit of sort of definition of what sarcopenia is. Sarcopenia is actually a term that came from the Greek word sarco, means flesh, penia, of course, loss of flesh, and in order to initially, the initial studies looked at only muscle bulk, and that probably was not appropriate. The most recent definition suggests that you have to look at three important aspects, which has to do with muscle strength, muscle quality and quantity, and performance. These three things need to be considered before you make the diagnosis of sarcopenia. And of course, it's important because it has negative impact on function. You have to separate or differentiate this from a number of things. Frailty, which is usually diagnosed differently, and it's really in the geriatric population, it's different than sarcopenia. Cachexia is also different than sarcopenia because there you lose not only muscle but also fat and other tissues, and of course it has a different implication. Now, how do you diagnose sarcopenia with those three components? The initial screening for sarcopenia is the SARS-F questionnaire, which is very simple, 5-item survey. That'll give you an idea. If you have a score of 4 or higher, then you at least know that there's a suspicion for sarcopenia. And then there's ways to address skeletal muscle strength with grip strength or chair stand. Then you look at skeletal muscle, so both in terms of quantity and quality, and then physical performance. I'll look at this in just a second with an algorithm. Now, there are multiple ways to look at muscle loss, and these include the DEXA scans. You can look at it with CT, MRI, ultrasound, and BAI. And the precision is similar in most of these tests, but in terms of availability and cost, of course, DEXA is probably the one that is easiest, most readily available, and it really needs very minimal minimal work. It does require, of course, for that study from the study, use the same standard for different studies. So using some of these tests, and here it was a sort of meta-analysis of different studies looking at different modalities. The prevalence ranged between 1.6% if you use MRI to 63% using DEXA. But most of the DEXA studies suggested a prevalence of about 12.2% in the NAFLD groups. Now, when you look at advanced fibrosis, then the prevalence is higher. What you look at biopsy, FIB4, or other non-invasive tests, transelastography or MRI. Then these are that sarcopenia and the fibrotic patients is associated with NAFLD with fibrosis. And some of these studies looked at other sort of associations with cardiac abnormalities. So there's some studies that suggested that it was associated with an increased thickness of intermedia and carotid plaques. There is also association with insulin resistance, as you would expect. Now, there is clear association with obesity. Here is a study that looked at what is called the skeletal muscle to visceral fat area, or SVR. This is not hepatitis C SVR. This is basically looking at whether visceral fat is actually playing a role. And in this context, there is a clear association between visceral fat to muscle ratio with development of sarcopenia in patients with MASLD. Now, interestingly, this is another meta-analysis, and what they found was that the association with increased sarcopenia was primarily in the Asian population. So they did not find association of risk of sarcopenia in the European and American studies. Unfortunately, I think the number of patients or a number of studies that were included here were very small because most of the studies came from Asia, from Korea, and other places. So I still think that there's a significant association between sarcopenia and NAFLD, regardless of where you are. Now, let me show you some of the studies that we've done. This is looking at NHANES 2017, 2018. Again, for those of you who are not familiar, NHANES is a population-based sort of data where patients come in every year and get tested. And in this context, they have lots of data, including most recent ones, including FibroScans and or transelastography, as well as lots of clinical data. And they also have DIXA scans as well. So when you look at sarcopenia, we defined it by the most recent definition. You see that sarcopenic NAFLD was associated with advanced fibrosis, and at least using NHANES data set. So when you, especially in the first part of the table, you see that significant fibrosis, which is F2 and higher, and advanced fibrosis much higher in patients who are actually sarcopenic versus non-sarcopenic. And when you look at sort of multivariate analysis, again, presence of sarcopenia is associated with significant fibrosis. And we also looked at the leisure time and physical activity. So if there is actually more physical activity, then that was inversely associated with sarcopenia. And that actually has implication for treatment of this complication of MASH or associated with MASH. Another study looked at mortality. For that we need earlier NHANES data where you have long-term mortality data. This time we looked at all chronic liver diseases. 35% of cohort that we chose of 12,000 patients had chronic liver disease. And as you can see, about 27% of them have NAFLD. Sarcopenia was much more common among patients with NAFLD than other chronic diseases. As you can see here, 41% of NAFLD patients had sarcopenia as defined here. And when you look at the LS7, this is lifestyle 7 metrics that's used for cardiac arrests. So that NAFLD and alcoholic liver disease patients who happen to have sarcopenia had less likely to meet the ideal LS7 metrics. And some of those are listed in the table to the right. So, but when you look at so again here, you look at the prevalence and NAFLD, alcoholic liver disease, and others in terms of sarcopenia and non-sarcopenia. And of course, when you look at the risk ratios, then NAFLD is very, very high. When you look at the higher risk of all-cause mortality, so patients with NAFLD with sarcopenia were the only patients that had high risk of all-cause mortality. So sarcopenia in the context of NAFLD was associated with mortality, not the other diseases that we have here, or including hepatitis B, hepatitis C, ALD, and the controls that did not have sarcopenia. And this was not only all-cause mortality, but also cardiovascular mortality. And again, when you look at the component of LS metrics, the LS7 metrics, body mass index, blood pressure control, physical activity, and glycemic control provided the strongest protection against sarcopenia. So these could be the targets of how to manage sarcopenic NAFLD in these patients. Another more recent study just looked at the NAFLD patients, again, 1999, 2004, 4,600 patients. And here, NAFLD was defined by fatty liver index. This is not because the earlier studies did not have transelastography. We used fatty liver index that was available for everything. The earlier studies did have ultrasound, so we validated for FLI, against ultrasound and against FibroScan. So there is validity to use this in population-based data. 29% had NAFLD. And then when you look at sarcopenia using the DIXA scan, this was a slightly different definition that was given by NIH. Sarcopenia was about 17%. Activity level was determined here by self-reports. So the interesting part of this is that sarcopenia is actually associated inversely with activity. So if you're inactive and you have NAFLD, then you have high rate of sarcopenia, 63.5 versus 42.6, just looking at the top. And when you look at mortality, then you can see that all-cause mortality, cardiac-specific mortality, and cancer-specific mortality was again associated with NAFLD patients with sarcopenia. So all of this studies suggest that first of all, certain component of cardiovascular risks, like body mass index and probably waist circumference is the same way, will be associated with NAFLD, inactivity associated with sarcopenia in patients with NAFLD. But once you have sarcopenia and NAFLD together, there's high rate of fibrosis and there's increased rate of mortality. So let me also show you, this is from Korean National Health, sort of the Korean version of enhanced data set. And again, they connected sarcopenia in the MASLD patients with the cardiovascular risks. So those patients who had both sarcopenia and NAFLD, especially those who had fibrosis, had a higher number of cardiovascular risk factors and high risk for cardiovascular mortality. And of course, they measure cardiovascular sort of risk as ASCVD, which is the newer version of the Framingham score for cardiac risk prediction. So now let's look at how some of these sort of things are put together in terms of the pathogenic pathway. And I'm going to summarize a number of different studies. This came from a review article that's very nice. If you want to get a good reference about this, this is the reference to look at. Aging itself actually leads to development of sarcopenia. As you know, that's a well-known fact. Obesity, insulin resistant, all actually increases the risk of sarcopenia. And this probably has to do with a number of things that obesity is associated. It's a pro-inflammatory sort of disease, and in that context, that leads to development of sarcopenia through causing abnormalities in the muscle and the liver also. That also leads to the liver sort of related diseases to sarcopenia. Adipose tissue, white adipose tissue, as I mentioned, is a endocrine organ in a decrease in adiponectin, an increase in the pro-inflammatory cytokines like TNF-alpha, etc., can actually lead to probably a decrease in insulin sensitivity on the muscle in causing sarcopenia. And finally, there are a number of muscle-specific sort of changes with myosteatosis, myostatin increase in the serum, and other things that can lead to development of muscle loss in sarcopenia. Now let's get back to the clinical assessment. Knowing that this is actually a high, there is a high association between sarcopenia and MASLD. So you have to watch out for this. Now, would you screen every patient for sarcopenia? That may not be the case, but you have to have a high suspicion for this. And the first test to do is SARC-F test, very easy to do. And if that's actually positive, you have a score of 4 or higher, then the second one is to do a muscle strength test. The easiest one is to do a hand grip or a chair stand. You can do it in the clinic, in the office. And if that's actually low, there's actually gender-specific or sex-specific sort of cutoffs for these. You can look at those, and then if that's abnormal, then you probably have sarcopenia in the patients. And then you have to go to the next one. We happen to use DIXA, but if you have availability for other things like, expertise in ultrasound or availability of MRI, then of course you can do this. And if you have abnormal DIXA, then you're confirming sarcopenia, and then you can start the intervention. But if you want to sort of grade how bad is sarcopenia, then you do some physical performance test, and this is basically the walk test, the gait speed test, and all of these things. And if these are abnormal, then you're dealing with severe sarcopenia. What are some of the managements? These are sort of listed here, from exercise, diet, nutrition supplement, and some of the hormonal supplementation. I can tell you that the last two, evidence supporting that is pretty meager and low. It's really the top two that you can consider, and that really has to do with exercise, especially resistant exercise. And it's about 35 to 40 minute sessions, about 2 to 3 times per week, is what's recommended. And then of course it will build the muscle bulk and strength and capacity, and that would be one of the important aspects of managing sarcopenia. Diet. There is, the optimizing sort of the protein intake, especially in the elder population, especially in the elderly with NAFLD that are also at risk have a multiple risk for sarcopenia. These are the individuals that you can continue to reduce sort of the calorie intake because you're dealing with obesity, but also make sure that there is adequate protein intake and some healthy fat that usually is in olive oil or other types of oil that will optimize the omega-3 sort of diet component can help. These are probably the two that has more evidence, and I would recommend supplementation with vitamin D or creatine and other things probably will not, it's not something I recommend, and testosterone is certainly not what I recommend at this point because the evidence for that is pretty low. So to summarize, what I described to you was MASH, that it is very common, and the global burden of this disease, this liver disease, is growing across the world. Now, historically, we use liver biopsies to risk stratify these patients, but more recently, the majority of guidelines recommend NITs. We all start with FIB4. Now, the cutoffs, I know in some countries like India is different than the one we use, but it is probably a good first test to use because it's so easy to do, it's cheap, and it's easily put into electronic health record. The treatment, which is really primarily focused on sort of patients that have some fibrosis, if 2 or higher, you have to really deal with comorbidities, so optimizing type 2 diabetes, optimizing obesity, and other cardiometabolic risk. First of all, with lifestyle, that's recommended for all MASLD patients, and of course, optimizing with drugs for type 2 diabetes. And there are drugs that you can use that will optimize the diabetes management, but may have some impact on NASH. Now, I wouldn't use those drugs like semaglutide right now to treat MASH, but I would use it to treat diabetes in patients with MASLD because there is phase 2 data that may suggest that it's going to work. But in the United States, at least in the United States, the only MASH targeted therapy is resmetirom. And I know in India, I think one of the PPARs is saraglitazar is approved in India for use of MASH, and that may be what you can do. Other regimens are being developed. I would say that sarcopenia is relatively common. You have to keep an eye for this complication because it's important to make the diagnosis. It has important implication for prognosis and can be an independent predictor of mortality in patients with MASH. There's a standard approach to screen for these patients and then verify your diagnosis. Treatment with exercise and diet is really the best way to focus on this. Hopefully in the future we'll have other things, but that's my recommendation. So I'm going to stop here and thank you all for your attention.